Hello, good morning, good afternoon, good evening. I don't know which part of the globe you all are watching this right now. Anyway, have a lovely day. I'd made a brief presentations on various subjects, especially with an objective of trying to get some clarity into questions that are asked in NEET. There have been requests from various social handles that I do some sort of, you know, in-depth analysis or in-depth presentations about some basic concepts which students very much wanted. So I thought I'll make a few MCQs and also take you through the basics of ultrasound. Now, what I want to tell, and one more thing, I want to thank you all very, very much. There was an upswing in my subscriber base this last month, and students have been my biggest cheerleaders. I really wish to continue to put up practical content asked in the NEET, OSCE, and fellowship exams. Actually, looking at it, these are day-to-day activities. Interns would have gone running to the ultrasound room at least 5 times in the day, getting the report, seeing the monitor. But then these are routine tasks we do. But then when we ask finer details in an exam, then we are stuck. So this is my attempt at trying to get the basics of ultrasound. Now, I'm neither a physicist nor a radiologist to give an in-depth analysis. But I will be just taking you through the very, very basic concept that as a clinician you must know, and more so when you're going to give a competitive exam. So these are just 4 MCQs, but they'll be trying to touch upon various practical aspects of the ultrasound and also the questions that are asked in your NEET, not more than 4. So the properties of medical ultrasound, we'll take up each compartment separately. Properties of medical ultrasound, the strengths of ultrasound as a imaging modality, and what is not true of an ultrasound, and finally this barcode sign. Actually, this barcode sign is a trending topic now, asked in many exams, and it's very simple. We'll come to it. So now coming to the basics, these are the piezoelectric crystals which are embedded in your transducer or your probe. This is your ultrasound probe. Fine. So you initiate the crystals which are kept here through your electric current. They start sending ultrasound waves into the tissues, and then those waves come back. Either they are absorbed, scattered, or returned back completely, picked up by the transducer, and again go into the monitor. There is a lot of physics involved. We are not going to go into it. But finally, what you get is a sort of a third eye. You're looking at tissues inside the body with your ultrasound. From the surface, this is not how the popliteal fossa will look. But then you go deeper because you had the ultrasound with you. So you have one more eye, which is your third eye, and this is your monitor. Okay, now you must know what you mean exactly by hypoechoic, anechoic, and hyperechoic. So let's have a look at the hypoechoic first. This is your liver. And what is anechoic? Totally black. So that is your fluid. And what is hyperechoic? Almost white, which is your kidney. That means this is reflecting all the ultrasound waves back. This is absorbing, not sending it. This is partially reflecting it back into the transducer. Once you get this template, it will be easy for you to interpret the ultrasound findings. Now, coming to the first multiple choice, the properties of a medical ultrasound is, one of the answers should be true. Lower the frequency, higher is the presentation. We'll have a look. Ultrasound to image intra-abdominal organs use more than 10 megahertz. No, they use 7 megahertz. So it is wrong. Range of the medical ultrasound is in the range of 2 to 25 megahertz. No, it's 2 to 20 megahertz. Now, ultrasound for thyroid needs lower frequency as it is superficial. Mind you, more superficial, you need higher frequency. Deeper, you need lower frequency. So this is wrong. So this is your right answer. So this is your right answer. So what will happen for an abdomen, we will be using lesser frequency, and for a thyroid, which is for an abdomen, we will use lesser frequency, and for a thyroid, we will be using higher frequency. That much you should know. And this principle, these two questions will answer, and you must know the range. So we'll show you the short video clipping of this ultrasound being done. Probe is being placed on the abdomen, and the monitor is being seen to see exactly what is the problem there. This is an abdominal ultrasound where you'll be using 7 megahertz. Now, the next question is, the following is not true of an ultrasound. Be very careful. There is a catch here. When they put like that, you have to be very careful. Ultrasound is the first investigation of choice in the liver, renal tract, and stomach. Next question is, it is operator dependent. Foreign bodies can be picked up in the soft tissues, highly attenuated by soft tissue. Soft tissue will absorb the ultrasound nicely. So the rays will get attenuated. Attenuated means suppressed or brought down. Now, is ultrasound the first choice of investigation in the liver and renal tract and stomach? In the liver and renal tract, it is first choice, but not stomach. See, they have included that stomach there. If you don't read this properly, you will go and straight away mark this answer. See, this is the liver. You can see the liver parenchyma. You can look at intrahepatic dilatation. See the dilatation there. You can see the gallbladder. You can see the ecotexture of the liver also. You can see the ecotexture of the liver. Similarly, you can see the kidney outline, the medullocautery junction. But stomach is difficult to see on ultrasound. It is not that you can, but when you have to answer a question, you have to factor in. So this stem has a stomach introduced. So this possibly cannot be the right answer. It is not true of an ultrasound. Is it operator dependent? Yes, it's very much operator dependent, unlike your CT or your MRI or your X-rays. Now, can you pick up foreign bodies in soft tissues? Yes, you can pick up. I'll show you this foreign body. In the soft tissue, there is a needle which got embedded, and it is highly attenuated by soft tissue. So what is not true? That should be your answer. What is not true is this. This is not true. Only because the word stomach has got included in that question. The following are strengths of ultrasound. It has no radiation, true, because it works by the piezoelectric effect. Then it's the first line of investigation in hepatic, biliary and renal. We had seen in the previous slide, but there the stomach got added, so that option was naturally eliminated. It is excellent for cysts and foreign bodies. You can see a cyst here, heterogeneous cyst. You can see a cyst here. It has got anechoic area and hypoechoic area. This is an ovarian cyst. You can see the bladder here. So it is excellent to pick up foreign body. I had shown you in the previous slide. It's excellent to pick up cysts. Dynamic studies cannot be performed. No, it can be performed. The patient will perform a movement while the physician holds the ultrasound probe relative to an anatomic landmark. This is very, very specific when you're trying to elicit probe tenderness at the McBurney's point in appendicitis or a sonographic Murphy sign. Keep the probe in the right hypochondrium, lateral to the rectus, where you expect the gallbladder to be. And when you're pressing on the gallbladder, if patient catches her breath, then it is acute cholecystitis. Whereas clinically, when you do the same test, there can be so many layers on the abdomen which can be tender, and you don't even know whether you're really pressing on the gallbladder or not. It is only surface anatomy. Whereas with an ultrasound probe, you know you're straight on the gallbladder and you're eliciting the sign. So a positive Murphy's is much more sensitive and specific when it comes to using an ultrasound rather than your clinical exam. So what exactly is the except is your answer. So no, you can do dynamic studies. So this is the correct answer. So these are the questions I tried to cover up and also brought the basics of mechanics of ultrasound and how much a physician should know about the physics of ultrasound. So this is the last question for the day. Barcode sign, as I told you, it's a trending entity now. It's repeatedly asked. Do you get it in a hydrothorax? No. You can see that it is a anechoic. See, absolutely no echoes. This is a pleural effusion or a hydrothorax. Look at hemothorax on an ultrasound. Anechoic, hypoechoic, grayish. Fine. So, and not only that, you also find a collapsed lung inside, which is hyperechoic. Inside the fluid, you have a collapsed lung. Inside the fluid, you have a collapsed lung. That is hemothorax. Coming to pyothorax, you will find hyperechoic, hypoechoic, anechoic, and strands, because that pus will start organizing now and form strands. This is classic of pyothorax. And what do you get? Barcode sign you get in pneumothorax, not necessarily tension pneumothorax, in pneumothorax itself. You see, the lung will look like sand particles. But then when you have a pneumothorax, the lung will look like this. See the layers? Like a barcode, because the air will come and nicely oppose itself between the layers of the pleura and the underlying lung. So this you have to remember. This is routinely asked. They may even give you an image spotter. So the correct answer is, what is a barcode sign? You get it in a pneumothorax. So I have just discussed only 4 MCQs on ultrasound, that too basics of ultrasound. And I may be taking more classes with more depth, but right now, as of now, this should suffice. Since you're getting your NEET exams very fast approaching, we didn't want to go into too much details about physics of ultrasound and other aspects of ultrasound. So please do ask. People have been asking, and that's why I'm putting these shorts or these short video reels. Thank you very much. I hope to have clarified certain doubts which were in students, and keep posting your queries and doubts, and I'll be too happy to make the necessary reels. For the next few days, I'll be concentrating on only MCQs rather than taking topics as such. And these MCQs will have adequate explanation there. It is not just ticking the right option that you can see by looking at the key. You don't need a teacher to explain. So if we are there in that process, then there must be some explanation to be done why an option is right, what would you find in that option and why it is not right, what would you find in the correct option and why the correct option is right. Thank you very much, and as usual I would ask you to subscribe, like and share. Please do join my Telegram channel also. So once again, signing off and thank you.